Good morning. Welcome attendees. I am Sonu Bhaskar, an academic neurologist and healthcare executive based in Sydney. I'm the director of New South Wales Brain Clot Bank, a flagship initiative that was established by the funding from the Ministry of Health in New South Wales. And I also sit on the board of the Rotary Club of Sydney. I'm really excited today to facilitate this panel on leadership development at academic health centers, cultivating innovation, community, diversity, and belonging. At the outset, I would really like to thank Dr. Kanta, who was our guest and visitor to the Partnership of Better Health Symposium in 2019. And I really this is all a teamwork. So I would like to thank Christine and Katie for the support and the background to facilitate this meeting. Well, we'd like to make this session as interactive as possible, so please feel free to turn on your videos and jump in on the conversations after each panelist has made their brief introductory remarks. You can use the chat box to make comments or ask questions of our panelists. Now, I just want to make a brief introduction about where we are today about diversity, belonging, and inclusion. So this is a safe space. A good idea can come from anywhere. Let's be inclusive of diversity of thought. Let's learn from each other's experiences. I also want to congratulate every one of you because you all are leaders in your own domains for taking leadership in pursuing inclusion and justice for your institutions and patients you serve. Really, you all are transforming your institutions, but it's really an important work, a hard work. Today, we want to move beyond numbers. And our focus will be to humanize our experiences through conversations. I'm reminded of the words of a Twitter star, to be honest, Dr. Jenny Benacardino. And she says, the journey of one immigrant is the journey of all immigrants. We often leave behind what we love the most, our families, to achieve our dreams. That price tag is very high. And it may mean to miss being the side of your dad when he dies. We got to make it work. As an immigrant myself, I share those compassion and the pain and trials and tribulations. And I'm sure most of you will. Diversity is going beyond representation and numbers. It's a place where you and I can be our authentic self, where our individual differences are respected. I quote, diversity is having the seat at the table, inclusion is having a voice, and belonging is having that voice being heard. Now, the question is why inclusion and diversity matters. It matters because its understanding improves equity and impacts healthcare workforce diversity, and it impacts wellness of healthcare workers. We'll hear that from Dr. Gold and Dr. Golden today. As two prominent psychiatrists on the panel, they will share their experiences from their institutions. And we'll talk about how can diversity influence the care to our patients and to our communities. Now, let me give you some evidence around what we are talking about today. A recent JAMA study found 6 broad factors that impact inclusion within the healthcare. Number 1, the presence of discrimination. Number 2, the silent witness, the people who witness discrimination. Number 3, the interplay of recognition and civility. Number 4, the effectiveness of organizational leadership and mentors. And number 5, the support for work-life balance and feeling excluded from inclusive efforts. Undoubtedly, inclusive workforce fosters a sense of belonging and community. As leaders, we all can do our bit to build inclusive workforce and workplaces. We have just released a call for action on frontiers in psychiatry on need to address equity and justice divide during COVID-19 and beyond. As you have noticed that COVID-19 is deepening inequity and injustice among the vulnerable communities. Now, as healthcare workers, we are vulnerable. We have been vulnerable. A number of significant portion of our healthcare workforce have been impacted because of COVID. Now, we all know that it is onerous that systemic issues must be addressed, not just during COVID, but beyond the COVID. And principles such as inclusion and diversity at academic health centers must be the front, left, right, and center of our debate. And that's why we're having this debate today. Now, the concern is that without these reinforcements, we'd not only compromise the efforts to build a sustainable healthcare system, but also its impact on vulnerable communities. So let's discuss today on some of the challenges that we face in healthcare from some of the opinion leaders in the field, and we'll reflect on those challenges and develop a shared understanding of what can be done to address them. On that note, let me introduce our first panelist today, Dr. Jessica Gold. She is the Director of Wellness, Engagement, and Outreach at the Department of Psychiatry, Washington University in St. Louis. Our second panelist today is Dr. Robert Golden. Dr. Golden is a psychiatrist as well, and he's the Vice Chancellor for Medical Affairs and the Dean of the School of Medicine at the University of Wisconsin-Madison. We also have a panelist from China. So we have an Asian representative here. He's the Vice President, Dr. Ming Kwang, who is the Vice President for the first affiliated hospital, Sun Yat-sen University, and Executive Vice Dean from Chongshan School of Medicine, Sun Yat-sen University. We have a panelist from Canada, Dr. Sarita Verma, Dean and the President and CEO of Northern Ontario School of Medicine. I've been following her work. She's quite active on Twitter and otherwise, but also she puts up an executive dean commentaries on many of the challenges that we face in healthcare. So please do follow her work. And of course, Dr. Gold, who is very active on Twitter as well. And if you want to have a conversation during this session, please tweet us on AAHC-I 2021. We are very active and we'll make sure we respond to you. On that note, can I invite Dr. Gold to make an introductory remark? Thank you, Dr. Gold.
Sure, no problem. Let me share my couple of slides so you can see them as well. Thank you for having me. So we were asked to talk a bit about something that happened in our careers that impacted us significantly. And, you know, one of the things that I do in my job is I work in physician wellness, and that's one of the things that I am most passionate about. And I'm also a writer. I spend a lot of my time writing for the popular press, and I write for places like Forbes and InStyle. And I kind of wanted to explain how I got to be interested in both, because I think that's the thing that brought all of this together for me. You know, when I was in college and I was a pre-med, of course, like many people, pre-med was challenging and it wasn't something that was super fun and exciting the entire time. But I think the time that was most eye-opening for me as a trainee, that showed to me that there are a lot of changes we needed to make to the way that we train physicians beyond pre-med, was when I was in medical school as a third year. My very first rotation, I had an experience that is what this piece is about, where I basically was, for lack of a better word, tricked into performing cardiac massage on a patient who was already dead. It was my very first rotation. I didn't really know what to do. I had no really ability to speak up because med school has hierarchy and you don't really know what to do. I did everything I was supposed to do in the case, and, you know, wasn't really aware that the person was not alive until pretty late in the case. I wrote about it, which I can read to you so you can see it. So I'll just read the beginning. Med student, go scrub in. After a stunned realization that I was in fact med student, I ran to wash my hands. Heart racing, I had no clue what was going on in the operating room. I also knew that this was definitely not the time or place to ask. In my role as a learning observer for the past 30 minutes, I had not done a very good job. It was chaotic, with about 15 people in the operating room, yelling and passing metal instruments that I'd never heard of, while others were running back and forth, delivering units of blood to the patient whose vital signs were rapidly dropping. All of this heightened action occurred around me like a play, while I, a lone 5'1" third-year medical student on her first night of call, simply tried to stay out of the way. The other medical student and I tried to piece together aspects of the case. We determined there was no bleeder in the chest and that they had found a splenic and liver lac in the abdomen. We heard the anesthesiologist say something about dropping blood pressure and its relationship to the placement of the clamp. I realized that if I looked at just the right angle, I could actually see the patient's heart, bigger than my fist, and a deep and almost crimson red beating through his now cracked open ribs. I also knew that he had lost a lot of blood. My shoes were drenched in it. And now I'd been singled out. They needed me. I hid my fears and tried not to break the sterile field as I squeezed through the massive blood-soaked surgical gowns. The attending filled me in on my role. You make your hands like an alligator, you put the heart in between and you pump it. That's how you do cardiac massage. Go. I thought to myself that someone more experienced should be doing this, but I felt powerless to say it out loud. Even though I'd never seen cardiac massage performed before, much less tried it out on a simulated patient, I believed that my actions were critical to prolonging the life of the patient. And so I went against my gut and did what I was told. Immediately, the attending told me that I was doing it wrong. This was truly a matter of life and death, and I was failing. I hated myself. Still not exact in my second attempt, the attending told me to forget it and passed me 2 syringes to inject into the patient's heart. Pointing on the heart where he wanted me to place the needle, he told me to take the cap off and just jab it in. I'd never even given a patient a shot in the arm. But this was a time not for hesitation or questioning. I was saving a life. Someone whispered over the curtain, "It's been a while." It was the anesthesiologist. The attending nodded, and then I heard the words that seemed to take me outside of myself. I had a feeling when you called the med student in. My stomach churned and my heart dropped. I could feel my own heartbeat in my throat. My hands were still pumping the patient's lifeless heart. The attending glanced at the clock, time of death, 2:05 a.m. So basically, when I figured out that when he said, I had a feeling when you called the med student in, it clicked to me that they knew the patient was dead when they called me in. And I ended up writing this piece because I didn't know what to do with my feelings. And I had been sort of writing as a way of journaling. And I wrote the piece really quickly after this happened and sent it to a mentor. And she said, one, I'm really sorry that happened to you. Those things should not happen. We need to talk about that and you need to tell someone. But also that this had an ability to really teach people. And it should be something that I talked about on a bigger level because it's about hierarchy, it's about medicine, it's about the things that we shouldn't be doing. And so not only did I bring it to a dean who basically said, this person does this, and that's something that this person has been reprimanded for before, and there's not much I can do about it, but I was also told to write about it. And so I wrote about it. This was in Annals of Internal Medicine. And when I wrote about it, people really responded, like much more than when I was in the office and had said something. When I was in the office, I felt really dismissed, like I had gave my complaint and it wasn't going anywhere. But when I wrote about it, I felt very much like I was making a difference and people were talking about it and people wanted to make change. And I think from there, really realized that you had a power of advocacy through your writing and through, sharing stories. And I think my mentor really was the one who pushed me to do it because I was just really angry and I could have just kind of, sat with my emotions and let it ride or just, been really frustrated about going to see someone and telling them what happened and not having anything come from it. But instead, really, I wrote about it. I felt like people heard me and I feel like that really motivated me to really think about these things moving forward and go into physician mental health and wellness and think about how these things impact people on a global scale. It's really impacted my writing moving forward. These are 2 pieces I've written in the past year about, the way that the pandemic has impacted our mental health. I do both kinds of pieces. I write narrative pieces and journalistic pieces now. So I write about my own experiences and the experiences of others, but I think it's really important that I know that stories matter and we can make change through stories and stories on a larger platform. And I do the same thing in social media. So I think that we can normalize mental health, and we can talk about mental health, and we can talk about the struggles that we have as physicians and other healthcare workers, and the things that we should be changing in our culture through talking about it on social. Because I think people go to us on social and they say, well, you're a healthcare worker. If you talk about going to see a therapist, if you talk about the things that you're struggling from, then maybe I can be struggling too. Or if you're a healthcare worker who follows me and then you see that too, you can also feel like it's normal to talk about it. So I've found that it's a way to use a platform and make bigger change. And I think it was all pretty much inspired by that experience that I had and the motivation from a mentor. And that's really defined like what I do and my passions in my career. So hopefully that's somewhat interesting to you guys. Feel free to follow me on Twitter. I talk about this stuff a lot. I write about this stuff a lot. If there's ever a topic that you want to talk about or have me write about, feel free to tip me. I like to write whatever people are interested in. And thank you for having me. I'll be here all day.
Thank you, Dr. Gold. It was, and really reminding us about how important are stories from a clinician experience and sharing those experiences, courage to share those experiences. On that note, can I invite Dr. Golden, please? Dr. Golden, over to you.
Thank you very much. And Jesse, thank you. That was very powerful, tough act to follow. If we could see my first slide. Like Jesse, I'm going to start out with a seminal event during my medical school years, and then share, next slide please, very briefly, two other events spanning my career. The first experience explains why I always wear a tie when I go to work. If we could see the next slide, please. On my very first medical school rotation, it was on the medicine service of the University Hospital, which was located on a medical school campus right across the street from the city hospital that took care of indigent patients. And on the first day of my rotation in the University Hospital, I noticed that all the attendings, who tended to be exclusively men, were wearing three-piece suits. And we were told as medical students that, like the residents, we were expected to always wear a tie and to be very respectful of the upper class clientele that we were taking care of. After that rotation, I rotated on the city hospital, and I showed up the first day of work wearing the same starched white shirt and tie that I would typically wear on the university hospital. And I noticed that the residents who had also rotated in the university hospital were wearing jeans and running shoes and sort of polo shirts. And I said to the intern I was working with, who was a graduate of that medical school, why isn't everybody wearing a shirt and tie? And he looked at me and said, you know, are you crazy? This is the hospital for the poor. We don't have to worry about whether they're going to come here or not. They got no other options, so we can wear whatever we damn please like wearing. And so at that moment, I made a pledge to myself that no matter what, I would always wear a tie when I went to work. And what it really symbolized to me was that every patient is the most important person in front of us. It doesn't matter whether they're rich or poor. It doesn't matter what the color of their skin or their religious beliefs or their political persuasion is. Every patient deserves the highest level of respect that we can muster. And I have always worn a tie ever since then. Next slide, please. Then I had the wonderful opportunity to move to Madison, Wisconsin in 2006 to serve as dean. And for my very first week in the job, I asked the office to arrange for me to meet with the department chairs, who I viewed as the key members of my leadership team. The School of Medicine and Public Health at Wisconsin has on the top floor a very traditional, long, somewhat impersonal boardroom. And I sat at the head of the table as people came in. And it was time for the meeting to get started, but it felt as though a lot of folks were missing. It felt as though the room wasn't really filled. So I gave it another 5 minutes and people were getting restless and all that. And I said, well, we'll get started as soon as all the chairs are here. And somebody spoke up bravely and said, excuse me, Dean Golden, but we have been all here for the last 5 minutes. And I realized that the reason why it felt like people were missing was that as I looked at this room, 25 of the 26 chairs were men, white men. And I had just assumed that people were missing because only one woman was there. And where was everybody else? So I made a pledge that we were going to be much more inclusive at our school in terms of gender, in terms of ethnicity, in terms of everything that falls under that rubric. And I'm very pleased to say that over the course of the subsequent decade, we reached a point where instead of 1 out of 26 chairs being a woman, we now have 14 out of 27 chairs are women. And all of the women and all the men who serve as chairs are outstanding individuals. It just took a commitment at the very top to build the groundswell support from the bottom that we could become more diverse at the leadership. Unfortunately, we have not been as successful in other important ways of diversity, but we're working on it. Next slide, please. Well, going back to where I was before moving to Madison, which was University of North Carolina at Chapel Hill, I want to share reflections about one of my heroes back there, who was also a dean. It's the legendary basketball coach, Dean Smith. People might not know this, but Dean Smith used basketball as a vehicle for really leading the integration of UNC Chapel Hill campus. He also used it as a bully pulpit to speak up in favor of women's rights and against the exploitation of women and children. So he's always been a hero of mine. Jesse, you might be interested to know that his wife is a psychiatrist who had trained with us. But Dean, in his own right, was an incredible person. And one of the lessons I learned from him was that he once said in one of his brief interviews, he really liked to put his players in front of the media rather than himself. He once said, you know, everybody loves offense watching basketball, but the game is really won on defense. And years later, as we've been working really hard to increase the diversity in our School of Medicine and Public Health, a couple of things happened. We recruited some absolutely fantastic leaders who increased the diversity of underrepresented medicine groups. And in 1 or 2 cases, after several years, they moved on. And the reason why they moved on was that we had a problem with the climate in our city schools, and in the School of Medicine and Public Health and in the university. And it really drove home the point to me that while everybody loves offense, the game is run on defense. And when it comes to diversity, everybody loves the numbers of people recruited. But the goal is really achieved by retention. And what that means is that we have to focus on the climate. We shouldn't simply work hard to recruit a diverse group. Once they get here, we have to make sure that the environment nurtures them, respects them, gives them what they need. And that's where our focus is on now. We are several years into an aggressive initiative called Building Community. And we want to make sure that our school is the kind of place with mutual respect and inclusivity so that we can have great offense and defense. We can recruit the best and the brightest from all walks of life. And once they get here, they will feel like they are part of the family rather than an outsider or a lone pioneer trying to make a difference. So those are 3 snapshots of ways in which my professional focus has been advanced, starting in med school and including lessons learned from Dean Smith, and also opportunities that have been challenges that we're taking on at our School of Medicine and Public Health. Thanks.
Thank you, Dr. Golden. Let me congratulate you. It was a fascinating presentation. And I must acknowledge that it's leadership that drives the systemic changes. And I think there's so much of work that's happening on inclusion and representation. But really today it's about moving on from that debate, from inclusion to belonging. I think you touched upon it how to nurture the leaders, how to make them feel belonged, so that not just they come and join, but they stay on. And it's important, and that the leaders like you drive those systemic changes. Thank you for that insight. Well, on that note, let me please welcome Dr. Ming Kwang, please. Dr. Kwang, take it on.
Okay. Can you hear me? Hello?
Yes, we can.
Sonu?
Yes, we can. Yes,
okay.
we can. Please go ahead.
Okay. I also can share some, before I share my slide, I want to say it's my great pleasure to participate in this very interesting discussion about the leadership, where I'm Dr. Ming Kwang, and I'm from Guangzhou, so I want to share you some slides very briefly. Yeah, can you? Sonu?
Yes, we can.
Can you
yes,
see that?
Please. Yeah, we can.
I'm
yes.
from the first affiliated hospital, Sinison University, and okay. Oh, yeah. And this city located in Guangzhou, right here, is the largest city in the south of China. So it's very close to Hong Kong and Macau. And in fact, I learned my medicine in Guangzhou, and I spent almost 4 years in Japan. And also I now as vice president of our hospital, I'm in charge of international collaboration, and also visit United States, Europe, and India many times. And the Sinison University is the top 10 university in China, the best in south of China. And the Wisconsin-Madison is the first Western hospital in China, and also the first medical school also in China. My medical school, we have a history of more than 155 years old. And also our medical school ranks #2 in China, where we have 10 affiliated hospitals. That's the second largest healthcare system in China. And this, my hospital, the first affiliated hospital, ranks #6 in China. And we can see these numbers of the patient we serve. So now I have 2 jobs in this system. I'm the vice president of the hospital, and also I am the standing vice dean of the medical school. So for me, I want to exchange my experience in this double work, and in these medical areas. And I want to talk more about that in our later on discussion room. So anyway, I have been I take the 2 jobs 5 years ago. So I really think to be a leader in both, in both parties, I think in both hospital and the medical school is somehow quite complicated, and so I think it's maybe not enough time to show to you in this the first maybe 5 minutes, but I would like to talk more about in our later on discussion about how to provide the leadership in this one of the biggest hospitals in China, and #2 medical school in China. So I can representing some Chinese leaders in both hospitals and the medical schools. So okay, I think you just gave me 7 minutes, so I can stop here, and we can share more things in our discussion. And okay, it's fine.
Thank you, Dr. Kwang. It's very insightful talk about, gave us a window of a view into the Chinese medical system, and of course the leadership there. But thank you for your thoughts. On that note, can I welcome, please, Dr. Sarita Verma, please?
Thank you, Sonu. A pleasure for me to follow 2 psychiatrists and a brilliant colleague from the 6th leading Chinese medical school. I'm going to share my screen, and while I'm doing that, to say I'm also deeply honored to be invited to this august gathering. So just gonna put this on full screen and screen show. Before I get started, I do want to acknowledge that the Northern Ontario School of Medicine, which is in the far north, yes, we're having snow today, that we are on the traditional lands of First Nations and Métis people. And we acknowledge that as settlers, we do not own these lands. And as part of that acknowledgement, it's important for all of us right now to reflect as to wherever we are, who originally was in those lands and what we did to actually reduce their ownership, but also their reality that many populations who were original Aboriginal in our countries have been decimated due to racist and oppressive mentalities. And that's actually a theme for me because as a person who came to Northern Ontario, my largest learning curve in Canada's smallest, yet actually one of the leading medical schools in Canada on social accountability, has been understanding the reality of Indigenous people. And so our focus at NOSM has been on social accountability. As Sonu knows, if you follow me on Twitter, I'm an avid anti-racist and a strong advocate for equity and for issues that address the power differential, Jesse, that you spoke about, the challenges of cultural change institutionally that Robert, you spoke about, and Ming-Kwan, the massive seismic shifts that are involved in actually leading innovation in a large academic health science center, while trying to maintain innovation, community diversity, and belonging. So it's all in your perspective. And my objectives are to identify some factors that influence culture and climate in institutions that AAHC-I is part of leading, and to discuss the role of our leadership in cultivating these issues. Let's start with the statement that I've run into many times. Well, actually, the most common thing I run into as a brown person in very white Northern Ontario, other than a strong Indigenous component, is, but where are you really from? And I say, well, I was born in the US, but where were you born? I was born in Iowa. Where is your family from? They're from the United States. Where did you go to medical school? Canada, and so on. And then of course, I'm not a racist, but, and then flows racism. And one of the big issues in racism is that we know, certainly around the world, and you know this from the pandemic, that health inequity is a cause of death. And in Canada, one of the most tragic things happened just several months ago was Joyce Escoban, who is an Indigenous woman who filmed her own death on Facebook as she was being screamed at by health professionals who were calling her terrible things like, you're only good for having babies, you're a pig, you're a slut, and she died. And she posted her live streaming, and the country was erupted with, as you did with George Floyd in the United States, with a sense of outrage and indignation demanding change. And there are assumptions with regards to underlying causes, like with the Indigenous people here, well, they're alcoholics and drug addicts, or they deserve what they get because they don't take care of themselves. The reservations are horrible places to live. Reservations, First Nations lands, which they own, have no food security, no water security, and personal security with murdered and missing Indigenous women is out of control. They have no accessibility to healthcare. They don't even have Wi-Fi. So I love the idea that let's have virtual medicine. La-di-da, they don't have Wi-Fi. And then finally, they have fear. They believe that healthcare institutions, as do many marginalized populations, are places where you go to die because you're not going to be well treated. Just look at the data on COVID-19. So I propose this statement: healthcare institutions must be culturally competent. They must address social, economic, environmental, and structural disparities that contribute to intergroup differences in health outcomes, both within and between societies. And they must address the unequal allocation of power and resources, including goods, services, and societal attention, which manifest these terrible conditions. We must foster transformation towards equity and inclusion through self-development, self-education, self-reflection, and personal change, but also at the institutional level. So things that you encountered, Jesse, or I have encountered, which are, statements like, well, you should learn to live with that. That happens. We have to address bias comments. And when you see them and someone says something to a patient or to students or to colleagues, we should be speaking up on it. Transforming institutions means that institutions, and I would challenge AAHC-I to include this in the AIM framework, which, you may not know, Stephen, but I know Christine and Elizabeth know I was very involved in developing. They should be looking at organizations that have norms, policies, and practices that are equitable and inclusive. Where is that standard in accreditation of medical schools that requires you to be socially accountable and demonstrate metrics of equity and create social change by working to social justice? This year, I declare it ad nauseam to be the year of climate change and social justice, and it has transformed our students. We must deal with microaggressions and bias. So for those of you who do not know what microaggressions are, they're like mosquito bites. One mosquito bite's okay. Like, I always ask, well, where are you really from? Or, do you speak English? Multiple mosquito bites in one day are microaggressions that just take over. Social accountability is something that people speak of. Ad nauseam, we live and breathe social accountability. It is embedded in who we are, in everything. And so that is, of course, the WHO definition that I'm showing you here, but it is part of our primary mandate. And we also have now begun to look at issues in the broader determinants of health, not the usual stuff that you look at in a 1-hour course in year 2 of medical school, but engagement of community, alliances, empowerment, decolonialization in our curriculum, advocacy, activism, and actionism. And we are, in fact, taking every approach, and we're going to be launching an inaugural Center for Social Accountability. In academic medicine, admissions and recruitment in residency, the curriculum, faculty recruitment, advancement, promotion, and tenure are all areas of social accountability. And they will address the structural inequities that lead to bias and socioeconomic inequity. Finally, I would challenge you to think about social awareness. We're in a world that's transformed now. Indigenous truth and reconciliation, certainly where I am, is a very important part of our need to address anti-racism. Black Lives Matter, I think, would be well informed, and you would be well informed around the world, as we were led by South Africa in the post-apartheid environment, to think of truth and reconciliation as the approach rather than ongoing combativeness. There is no doubt that medical schools are going to have to grapple with the effect of climate change, and that is an issue of health inequity. Don't underestimate mass movements that we've seen that are generated by outrage. And then finally, the power of the video as witness to everything we do. And social media, as you've noted, Sonu, very powerful. So finally, at our school, we've launched what's called the Respect the Difference campaign. It's acknowledging that 99% of our DNA is the same, but we should respect the difference. So I'll close with this call to action. I'd like to see AAHC-I put into effect a charter that leads to a statement on all institutions addressing health inequities and social accountability. Thank you.
Well, thank you, Dr. Verma. That was a very sobering presentation and a finale to the series of presentations we heard today. And, as a person of brown color or of multi-ethnic diversity, I'm often asked the question, when are you going back? Because I'm still a traveler or an immigrant who's probably doesn't belong here. So that sense of belonging is so important. And thank you for reminding all of us how important are these drivers. And people ask this question often, that why is accountability important? Accountability is important to heal. If the George Floyd case in America has highlighted anything, is that systemic disparities, if you continue to be apathetic towards them, it would not heal, it will create more divide. So it's important to take accountability as a means to heal within us and beyond us. So thank you for that reminder, Dr. Verma. Now, really the floor is open to questions and discussions. And I would ask the audience to please jump in if you want to have a question, raise your hand and ask questions. And I will be continuing engaging.
I have two comments.
Yes.
This is
yes, Dr. Saik. Yes, please. Yeah.
First one is related to the fact that yes, position statements, yes, publications, yes, presentations, etc. They are important. But in my opinion, the most important thing is education from early on in medical school. Because these are the people who are going to become department chairs and deans and leaders. If you tell them at that stage of my life, you should do this and don't do this and discriminate and don't discriminate, I honestly don't think it's going to be very effective. Maybe if you have accountability, they will do it because they don't want to do something wrong. But I think we want them to do the right thing. And in order to do the right thing, we got to involve early education from medical school on this very important issue. The other issue that I believe we don't talk about is not related directly to diversity, is the issue of leadership is about creating leaders. When you create future leaders, which we don't do when we are leaders, it automatically leads to resolving the issues of diversity because you are creating opportunities. There was an interesting article several years back in JAMA talking about department chairs of internal medicine, that many of the job vacancies are being occupied by interim chairs because there are no people who are either interested or at the level of taking department chairs. So it is also the responsibility of leaders to create or foster or mentor future leaders, of course, of all ethnicities and colors, etc., etc. But creating future leaders is partly the solution of this problem that we are facing, where only very few people reach leaders, and they are of a certain, ethnicity, etc. So these are my 2 points. Thank you.
Thank you, Dr. Saik. And let me pick on your proposition and throw it back to the panel. And Dr. Verma, if I can engage with you, could you please give us insights from your experience as an inclusive leader in Canada, that how can we build leadership that is sensitive and inclusive, and that is driven with some of the parameters that you were talking about. So could you please share your insights from Canada, please? Thank you.
Oh, thank you, Sonu. And, I don't think anybody has the right answer. And certainly we're all learners and we're all teachers. And so I think we first have to acknowledge that there has to be a set of competencies that we agree upon. And that could apply to learners, to faculty, to leaders. And I believe, I'm an educator, so I do believe that a sequential level of skill can be identified in terms of all kinds of ways to build inclusivity and diversity. We can identify the competencies that are required to show tolerance, to demonstrate conflict resolution, to actually show cultural competencies. There are wonderful ways to learn how to be culturally competent. And the acquisition of those competencies and the measurement of them from everything from recruitment to promotion to admissions and woven throughout the curriculum. I love the comment I think Dr. Gracias has made about the unwritten curriculum. We call it the hidden curriculum here. But I think all of that actually is measurable and it is doable. So being very pragmatic, our approach has been to say, outside of the motherhood statements and all of the lovable, attitudes, in fact, Dr. Saye spoke about, the impact will be felt by actually concretely identifying those competencies, including them in evaluation and in all kinds of ways to incentivize leaders. Finally, I want to say that leadership comes from the top. And, in fact, Dr. Golden pointed this out, that if it isn't actually built into the institutional culture, right? And he said they had climate, I think you used, but I think it was a cultural issue in the city, in the institution, in the hospital, in the schools. I think we have a lot of work to do, but I'm actually incredibly optimistic, much more than I ever have been, because we're in a culture right now that dialogue is happening, and it's been spurred on by all these events. We're having a session like this. 10 years ago, that wouldn't have happened. So thank you for holding this. I am inspired by it, and I hope that competency-based approaches will be the way that academic health science centers should pursue this.
Thank you, Dr. Verma. And Dr. Golden, if I can ask you that, if you could reflect on this particular question, but also weigh in on that, what are the models that we can follow to promote culturally competent systems?
Well, thank you. Those are two really big topics. I'll try to be brief. We've developed an approach to growing our own leaders in a way that is designed also to enhance the diversity of our leadership team. And it's worked well for us, albeit with, like any treatment, it has a unwanted side effect. So we started in partnership with our academic health system, we started a leadership training program. And of course, we solicited, nominations from department chairs, but then we specifically went after the most diverse group. And we've had several cycles of this. It's a group of about 15 to 18 people who meet once a month over the course of first 12, now 18 months. And we hook them in with what they think they really need, which is the hard stuff, finance, administrative mechanisms. But what the hidden curriculum is to emphasize ways of being inclusive, to emphasize the values of a respectful community. And again, we oversample, so to speak, people of color, women, people who self-identify as being LGBTQT. And then once they have graduated from that program, whenever there is an important opportunity for service on a leadership committee, a strategic planning committee, a search committee, we draw from that pool. So it's a pipeline that accentuates and expands on our limited representation, so that as we are growing our own leaders, we are more diverse than if we just let nature take its course. And it's been very, very effective. Now, the unwanted side effect is that these wonderful people who get these great experiences are prime targets for recruitment away from our rivals. And we've lost a lot of our graduates to other schools, but that's okay. I keep telling myself when we lose a wonderful colleague, well, we're spreading the good across the nation. And it inspires us to try to raid those targets as well. What goes around comes around. So we have found that growing our own and instilling them with both a overt and a hidden curriculum that emphasizes community, emphasizes collaboration, cultural respect, that's been really quite effective for us anyway. And I'm sorry, Sonu, I was rambling. What was the other question you wanted me to ramble on about?
No, Dr. Golden, the other question was about how do we promote the culturally competent system?
Oh, yes. Well, I'll tell you how not to promote it. The worst way to demote it is to give highly idealistic lectures and then not practice what you preach. And we had real problems going back a number of years where we were emphasizing cultural diversity, cultural respect. And then we had one or two bad apples among our faculty who were disrespectful. Fortunately, our students were brave enough to report that back to us, and we took decisive action. So I completely agree with what Sarita said, that it's got to start at the top and you have to walk the walk. If you are hypocritical, it's worse than being silent. Silence is terrible. Silence is consent, but hypocrisy is horrible. So that's why our approach, which is not necessarily the best approach, is to focus on leaders, bring in leaders who have a track record of walking the walk, and they can be the role models for their faculty, who can then be the role models for the students. That's the strategy that we have taken.
Thank you, Dr. Golden. Walk the walk and walk the talk. Two important things that I think so important for all of us to be reminded. Dr. Gold, next question is for you. And I really want to invite, I think one of the questions that have been asked by Valeria Aoki from, I think, Brazil. Dr. Aoki, if you would like to ask the question yourself.
Oh, hello. Thank you very much for the inspirational talks. I just wanted to make a point here from the patient's view. I'm a dermatologist, and there's a whole movement of ethnicity in skin. So for instance, we have a lot of clinical trials with therapeutic drugs, but all the consensus are based on Caucasian skin. So some aspects cannot be addressed to Asian skin or Black skin. So there's a global movement towards this other matter. So how are we going to involve research or other points of science, or even teaching, if you don't include diversity as well?
Thank you, Dr. Aoki. And Dr. Gold, if you can answer that question, if you'd like to take that one, if you wish.
Like how do you not include diversity? I mean, that's a problem of history. We shouldn't be doing that moving forward at all. I mean, I think we know so many examples of, you know, skin is one thing, but there's just so many examples of how racism has impacted the very system that we are in. You know, birth is a very good example. People die in childbirth that are of like Black in the United States that should not be dying in childbirth. If you look at COVID rates of death, the death rates should not be the way they are, and we should be talking about that more openly. Even if you just look at the disparities in healthcare worker deaths, the differences by race are substantial, because if you think about who's actually right there front line taking care of patients much more at risk, it ends up being people of color. And we don't talk about that. And we need to be talking about that, because we're often talking about the people who go on TV and talk as doctors and talk about what it's like to be a healthcare worker. And the people who talk on TV are like me and are white doctors, instead of, you know, people of color who work in frontline work in the hospital and can talk about their experience. So we, even within our own culture, miss hearing what it's like to actually be in our culture, right? So we are missing the stories and the experiences throughout so many different ways. So, I mean, I think we have to do complete revamps of the curriculum, from making sure that it is culturally diverse and in so many different ways. I think one of the things that is the hardest is making sure it is funded and the people working on it are not doing it for free. I think we often create positions where we assume people can do diversity and equity work and they can do that in their free time, or that it can fall on their shoulders for fun. As if that's just something else they can do. And it's hard work and it's important work, and it should be valued with financial investment. I think people need to be given money and time and prioritized to do that. I also think that it often falls on the shoulder of people of color to do those jobs. And I think that needs to be said out loud, because at the same time that it's important that we have the perspectives of people of color doing those roles because they understand the topics a lot better, there's a burden that comes with that. And I think we don't talk about that enough, especially the mental health burden of that, which is being the only person often and having to be the person who's also mentoring every person of color in a medical school and the person who's, you know, doing the entire revamp of a curriculum and responsible for making sure that everybody feels safe. That's a lot of pressure. That's a lot of work. And then on top of it, living in a racially unequal like society that is, you know, having its own, you know, struggles and making it really hard to live in, right? So I think we just need to be aware of these things and making sure we say some more of these things out loud, which I don't think we like to say in medicine either, which is that like we value these roles. These roles are not easy, that like being a person who does them is really not only really important, but really hard. And we had to give people the time, energy, and money to do them, and also not expect it. You know, I think that sometimes you should also give the person the choice, right? Like, I think we also sometimes are just like, that person in our department who happens to be a person of color obviously wants to be the person revamping the curriculum right now, right? But like, why? I mean, that's not fair, you know? I mean, that's an assumption. That's not a fair assumption. So I think we have to take into account that there's a choice there, and it's not an assumption either. And there's definitely a mental health burden to a lot of this.
Thank you, Jessie. And if I were to pick one of the comments from somebody, Dr. Maggie McDonald, and she writes that, what are the actions that we can take as leaders? So I think to begin with, listening, you know, listening to grievances, understanding that empathetic listening does a lot of difference. We tend to ignore that fact. As clinicians, we are really powerful. If we can pay listen for first 3 minutes or 6 minutes, that makes a huge difference. And we are listening today, and we are reflecting on our challenges. That's very important. I think one of the challenges I really want to engage with the broader panelists and our attendees today. As you know, after the beginning of COVID, in the British Parliament commissioned an inquiry into the disproportionate number of deaths among BAME healthcare workers, so people from vulnerable communities, especially the healthcare workers in UK. And the report has just been released a couple of weeks ago, and the report is actually a denial that the problem exists. So one of the questions I want to ask all of you is, what do we do about denial? Because as I said, there's one thing to acknowledge, but the systems have been structured in a way because of political leadership or otherwise, which tries to deny that disparities exist. And how do we as healthcare leaders from academic health centers play a role in that? I would bring that question to Dr. Kwong, if Dr. Kwong, if you could reflect on this from the leadership from China, and how do we address these problems? And I'm aware that you know, many of the healthcare workers from China in UK were also disproportionately affected. If you could share your thoughts on that, that'd be really valuable. Thank you, Dr. Kwong.
Thank you. And in fact, yeah, the COVID-19 also is, you know, is a panic also in China. In fact, at that time, our hospital sent a team, a rescue team, about 151 person, doctors and nurses to Wuhan, you know, epicenter at that time. Okay, in fact, I am the general captain. in fact, so you know, at that time, I'm in charge of the training. In fact, I do believe that. And I set up a new curriculum. I have never known. In fact, at the first beginning, I know nothing about that disease. But I was told we must try out everything we can, use every resource we have to save every life. In fact, no matter how old and no matter what's you know, what color he is or she is. So that's why we set a new curriculum from zero. The way set on camp is there in the nurses, and also we said with the new curriculum, we trained everyone and to save the patient. So I think the first thing I do believe is that, I am a surgeon. At the beginning, I almost forgot. In fact, frankly speaking, I almost forgot how to control, an infection disease at the first time. So I have a very short time of the reaction because we are really short of the ICU doctors and infection and disease experts. So we have to concentrate every person we got to the, to the disease where, so the patient there. So concentrate all patients, concentrate doctors and nurses into one small place, into one city, okay? So we learn a lot. In fact, I do think so. At that time, the first thing about the leadership is how to lead a multidisciplinary team to save lives. So that's a very hard, very unforgettable experience for myself. And also, we set a headquarters in that city and also headquarters in Guangzhou. And I, for 3 months, I trained with my curriculum. I trained on 250,000 faculty. Yes, that's unbelievable. So no matter, for me, I don't care about who is saying that, who is saying that. I lead my team to save everyone we met, save every patient we have. So at that time, we see almost 85 patients in ICU, very sick, the patient. And we get everything, and we get a material from Guangzhou. Every flight to the airport, we use a vehicle. We drive the car to get back everything. So it's at that time. So for me, I'm a doctor, and every person in my team. So I say it's an experience for me. So I always have a hope, and means even in the darkest time. So I do hope. So I still have the hope for medical education. That's why, as the dean of the hospital, vice dean of the medical school, I am doing something. So I will combine the public health in our old medical education curriculum. I want my future doctors to receive more education in public health. It's not just to be a surgeon, not just to be a physician. We need something because, China was hit in 2003 by SARS. And then 17 years later, another thing is about COVID-19. That means this pandemic is something disease we must face in the future. So that's why I'm working on that. So putting the curriculum of public health into the medical students' curriculum. That at least in my university, I can do it. And I am doing it. And I get many support from the president and also the local government. Also, they are supporting me to do that. So why not? So I do think for this thing, action is important. I do it. Thank you.
Thank you, Dr. Kwang. And I thank you for sharing your insights from China. It's been, Chinese leadership has been phenomenal in these times, and thank you for your reflections on that. I just want to pick up a question from Dr. Almeida, who says that the challenges about public health professionals face in promoting culturally competent services. Dr. Verma, if you could take up this question, I would really appreciate that.
Pleasure, and good question, Dr. Almeida. So let me just say that I have a transformative disruptor. And the thing that I would like to see is the change in the hierarchy, almost a military method in clinical and medical education that extends itself to then the circle of health professionals where there's a hierarchy. So, there's a power differential there. There's an academic and remunerative hierarchy. There's a leadership hierarchy. And in that hierarchy, first of all, in doctors, it's the student, the clerk, the intern, the resident, the chief resident, the attending staff, the chief of staff, the CEO, and everyone has a Trump order. And then on the side are the nurses, the PTs, the OTs, the speech therapists, the respiratory therapists, and along all of that hierarchy. So there's this almost ongoing Game of Thrones battle that goes on, that actually each tribe is trying to outwit each other and outplay each other and outdo each other. And what happens is, as Gandhi would have said, an eye to an eye leads to people being blind, or someone said that anyway. And that's what's happening right now in the chaos of the hierarchy. So I think two things. One is the disruptor, and to answer your previous question, needs to actually call out these issues. You need to speak up. And in terms of diverse populations and all of these issues, for example, in British Columbia, there's a fantastic report called In Plain Sight, which issued about 3 or 4 months ago, spoke clearly about inequities and this power differential. And then secondly, I would say that with regards to, the hierarchy amongst what I call the feudal system amongst health professions, we need to actually stop that. All members of the interdisciplinary team are relevant and important in the care of a patient. And in fact, often the social worker or the nurse is far more important, or even the ward clerk, in terms of communicating with the patient than the physician, who might actually be the worst. So we have to acknowledge our weaknesses. And then, as I said, go to those interdisciplinary competencies that respect each other. So finally, in my opinion, respect amongst and between health professionals is a cultural competency that I'd like to see measured.
Thank you, Dr. Verma. Dr. Golden, if I can take that in a continuity from Dr. Verma, I think you reflected on, your department challenges, as you gave some insights about the long boardroom you used to have, and then a predominant majority of them as white male physicians, and you saw that you drove that change over some years, and diverse populations were integrated in part of the healthcare, so on and so forth. But there was a problem of retention, if I understand. Now, how do you address these challenges, and what are your learnings from those challenges, or mitigating those challenges from your experience?
Well, there has to be a deliberate focus on creating the culture, the climate that is one of inclusivity. And there are several aspects to that. I think the most effective ones from a behavioralist perspective is a lot of positive reinforcement for doing the right thing, to make it attractive, to embrace a sense of community and team spirit. Unfortunately, any bell-shaped curve is going to have some outliers, and there are a couple of, bad apples that can really disrupt things. And so there also has to be a clearly stated policy of we don't tolerate bigotry. We don't tolerate lack of professionalism. It's not enough to avoid being terrible, but rather, being obnoxious is not something. And we bake into all of our letters of offer a standard paragraph about professionalism, that we hold everybody accountable to the highest standards of professionalism. So I think that's effective. My wonderful senior associate dean for academic affairs, Liz Petty, who had to sign off but was with us earlier, she is taking the lead on an emphasis on building community that includes a lot of institutional wide as well as divisional events to really share joy and build connections across the diverse elements of our community. So I think taking a real positive attitude is very important, and reinforcing what we value. But I also want to build on the recent response to a number of questions about the integration of medicine and public health. People might not know our idiosyncratic history, I imagine, but about 15 years ago, we took a bold step of declaring that we were going to transform from a medical school to a school of medicine and public health, not separate, but integrated, weaving into all of our missions of education, research, and service, the principles of public health. We do have a couple of departments that are typically found in schools of public health, biostatistics and informatics, a Department of Public Health Sciences, but we didn't want to keep those siloed. So we've revamped our curriculum. All of our MD students, all of them, are exposed to public health, woven into the core preclinical courses and woven into many of the clinical experiences in infectious diseases. They'll see needle exchange programs as well as clinics where sexually transmitted diseases can be diagnosed and treated. So everybody gets that as a base. For interested students, we encourage them to take additional coursework and earn a certificate. We created an MPH program with an eye towards it being primarily designed for dual degrees, whether it's MD, MPH, or nursing, even law, pharmacy, physical therapy. And that's for people who want more. And then at the top, there is a combined MD, PhD program in population health sciences. And so we have created a synthetic model. I agree that talk about disparities. There are disparities. In our country, the lack of funding for public health is a disgrace. For public health services and for rigorous education at all levels. We did a project going into our local high schools and found that when high school students were asked to list what is part of the health professions, they would always include, in addition to medicine, dentistry, nursing, pharmacy, but they never thought about public health. And so we've tried to really emphasize it, not as being a sidebar, although we respect those people who dedicate themselves full time to leadership in public health and service in public health, but also as a component. You've got to treat both the patient and the population if you want to have better outcomes, and nothing like this crisis to drive that home. We've learned that the power of medicine in creating vaccines isn't going to go very far if we don't have adequate systems for vaccinations. So those are the kinds of approaches that we've taken.
Thank you, Dr. Golden, and I think very insightful messages there. Dr. Gold, I have a question for you, and it's actually, following your Twitter, Tama, you're quite active on Twitter, and you're a strong advocate for engagement. I think medicine has always been a profession of service, and of late there is a debate about that we need to move on from service to community engagement, because service is there, which is an integral part of medicine, but really taking the healthcare leadership to be the forefront of community engagement. Now, how important is social media advocacy in driving that change? I would really like your insights on that. Thank you.
Oh, I love social media. I mean, I think it gets a bad rep. And I think that, all things popular, pressy, social media get a bad rep in medicine. And we live in a plane of academia where we think the only thing you can do to help people is write research papers. But research papers are read by like 10 people on average. And a piece that I would write for Forbes would be read by like a lot of thousands of people. So you can make a big difference, advocating on a bigger plane, same with Twitter, right? So I think that you have the ability to talk directly to patients when you're on social media. You have the ability to correct misinformation, right? So the bulk of misinformation comes from people saying things on social media, from people picking up headlines and not reading the article, from people saying something about vaccinations and going forward with it. If we're not on social media, who is, right? And so I think that it's our responsibility to be there and help, because otherwise we're having the people who are trying to propagate the information are the doctors that are using their license to do bad, or are the doctors that don't really know what they're talking about, or are the people trying to sell stuff. And so you have the people who are trying to do good and actually want to help people need to be there so that they can, engage with the patients who have questions, because there are a lot of people saying things that are dangerous, and you're not doing treatment there. You're just an educator, and we're educators in so many different ways, right? We teach in class, we teach in talk that we could give. We teach in a community. We go to churches and give talks. We go to a community hall and talk about things. We might want people to get vaccinations, so we go to schools and talk about things. It's the same thing. You're just targeting the population who might find you on Twitter, right? And so I think, for me, I've taken to that being a platform I can talk about mental health as much as I can, because there aren't a lot of mental health professionals that use Twitter and not well. And I think that mental health is really stigmatized. And for one, you can use it to be a normal person, so they know that they can get treatment from people who aren't scary. and two, you can use it to say, like, no, not every person who does mass shootings has mental illness. That's a big thing that comes up all the time for us. And I think there's just so many different things that come up all the time that, like, to me, be part of being professional in medicine should be being an advocate. And one of the ways to be an advocate should be taught to use your voice in a public space, because otherwise politicians are taught to do it, celebrities are taught to do it, and we aren't. And we are at a severe disadvantage to be able to communicate with our patients at a public level.
Thank you, Dr. Gold. And I'm sure that my panelists will not disagree with me when I will say that Dr. Verma, Dr. Gold and me, we are all requesting all of you to please be active on social media. And we would really appreciate your support in that community engagement as we build the platform for together. And these platforms that AAHC-I has provided us today is the beginning of many platforms that we will look forward in future. Now, I'm minded of times, we've got 10 more minutes, and I really want to focus on action and change for next 10 minutes. In that action and change, my first question is to Dr. Gold and then Dr. Kwong, and then I'll take up the question with Dr. Verma for concluding remarks and Dr. Gold. Dr. Golden, you touch base upon the deficiencies of the system, the barriers and the difficulties you have. Now, give us some insights on how do we embed the reward system to encourage and reward diverse leaders. One of the problems of the system has been that people from diverse underrepresented communities, they're likely to be there, but they're likely to leave as well. Now, how do we reward competencies like social media engagement, community engagement, all of these, which doesn't go into the H indices of the people while they're getting professorships, but how do we embed these, the other engagements, part of our model to create leadership that is inclusive, that rewards leaders who are, doing the engagement? Thank you.
Wow, what a wonderful question. One that I think about pretty much every week. So starting at the top, I ask each of my direct reports to fill out an annual self-assessment of how they've been doing, and also an assessment of how I've been doing and my team have been doing. And there are some standard questions each year. What are your goals and the metrics for those goals for the next year, for the next 5 years? But then there are rotating ones. And one that falls in the category now of permanent is a question of, please describe what you have done to increase inclusivity and diversity within your department. And when they're asked to give their 5 main goals with metrics for the coming year, it's an expectation that one of them will relate either to diversity or inclusivity or something related to climate as one of their goals. And when we sit down for their annual review, that's up there. It's not enough to simply look at NIH grants. We're also going to look about what have you done to make your department a better place. So that's one thing. We also started doing much more communication during the early stages of COVID because people were desperate to recover some sense of connectivity. So 2 or 3 times a week, we send out something electronically to everybody in our school called In the Know. And there's a section of it that includes shout outs where people can shout out a colleague. Maybe it's their unit clerk who was especially kind to a frightened patient or whatever. And we publish those as a way of highlighting, not just among the faculty, but among the frontline troops. Those small, important miracles that take place every day of human kindness and empathy. And then we have an alumni magazine like everybody. Ours comes out 4 times a year, so it's got the creative title of the quarterly. And we have shifted away to a more balanced portfolio. Instead of only emphasizing the latest research breakthrough, and I have profound respect for research breakthroughs, but that's just one part of the tapestry. We deliberately also focus in on either a student, a staff, a faculty member, or an alum who has done something wonderful in their community or has done outreach to our native tribes in creating a new clinic under the leadership of the tribes rather than us telling them what they need. So we have tried to find multiple ways, building on what Jesse said about the power of social media as well, but also traditional media, to really focus and celebrate not only the people who got elected to the National Academy of Medicine, but to celebrate those people who went out of their way to help a scared person who didn't have English as a first language navigate the complexities of the ER.
Well, thank you, Dr. Golden. Very sobering thoughts there. And on that note, Dr. Kwong, I really want to bring you into the panel. And I was, what would be your recommendations that you would take from here, but also from a Chinese medical system perspective, to embed reward in supporting underrepresented groups in the academic health center? Dr. Kwong, for you.
Yeah, thank you. So, yeah, I believe that the medical education is very important, and especially for medical education. So that one thing is I am embedding the leadership course into both the medical students, medical schools curriculum, and also the specialist training programs. That means the resident training program. And also we are cooperating. In fact, in the old times, we don't have that leadership course in China, in the medical school. So that's why for the past 5 years, we are cooperating with, for example, Association of Medical Education in Europe, AMI, and they will have 5 years collaboration, and they send doctor and experts into my medical school and also my hospital. We open the leadership course and also for the other basic medical education course. So we give that training for both students and specialists. And we do think it's a very good way to establish it. That's from zero to now. And also we have another thing is for the, that's for the young doctors and the residents, and also for the older doctors, we have open policy. That means we are pushing everyone to be more open to the world. That's why we have a joint, a chairman open not for Chinese, but open to the all people from UK, from Australia, and from the United States. And also, for example, our a joint specialist for the robotic surgery center. The co-director is from the UCLA Psychiatry Center, and also from the chief scientific officer is Joseph Song from Chinese University of Hong Kong. And also with this change of the leadership, that we allow the multicultural into, the influence into our medical society. That's I do think we are benefited for that. And also I agree with you, is your last question is very important, that social media. That's why for the we are also, for the in the past time, we are a little bit separated from the community because we have two professionals. And then the people they know little about the medicine. That's why for the past several years we are open more and more open to the public. For me, for example, every month I will go to the park. We have an open introduction about introducing disease, for example, liver cancer. We have that to the audience. The audience is not doctors; they are people in the streets. So that's you can hear very interesting. So that's why when we are doing this, that's a third action. So I briefly, we are changing the curriculum and we open more to the world, and also we are more close to the society.
Thank you, Dr. Kwan. I think you reflected on a very important issue, that engagement doesn't mean social media. Engagement also means, park engagements, community engagements, going into the community and talking to people.
Yes.
All the engagements, it's really broader societal engagement that is important. Thank you for those thoughts. And really today, I really wanted to focus on two women leaders, and that's why I've kept the best. Apologies for that, but two of our panelists today who are leaders in their own light, and I really want to have their opinion about, and it's very mindful that I bring this question to you, Dr. Verma and Dr. Gold. Dr. Verma, how do you in your leadership practice, how would you encourage women who are doing extraordinary work in medicine, so on and so forth, to take leadership positions? Because one of the problems that we face is that the women and also people from diverse communities, they are less likely to take, leadership roles. How do we encourage that practice within the community? Dr. Verma, over to you.
Thank you. Well, the reality is there are more men named Michael on the TSN index than there are women as CEOs. And our national paper, the Globe and Mail, has been doing a series of exposés on pay equity. And women as general are paid 20 to 25% less for exactly the same specialties, subspecialties, or work in medicine, law, and many professions. And so those two issues of recruitment and coaching, mentorship by women who are in leadership, we're doing that very much so. In the top 20 most powerful people in Canada, according to the Medical Post, I think a majority of them were women. I was number 20, but that's okay. And but I did score above David Naylor, who was my mentor. And the other thing is pay equity. So I think we have to advocate for that, because women are not only responsible for one job, they're responsible for 3 or 4. They're caregivers, they're the leading parent often, and they are the house caretaker, etc., and they are the physician. So in academic and clinical medicine, there has to be a much more aggressive approach towards recruitment. And I'm just going to close with the saying, from someone else, which is, I believe that the whole issue about diversity and equity is about justice, and justice will never be served until those who are unaffected are as outraged as those who are. And so whether or not you're of a women or equity-based group, everyone needs to participate in this conversation. So I would encourage anyone who has privilege of any kind to be mindful and reflective of the impact that they have on individuals or in their communities and institutions.
Thank you, Dr. Verma, and very sobering thoughts. And I think that reminds us that I just want to acknowledge all the attendees today, and especially women and people of color who joined, and for your leadership in your domain. So I really want to say that loud, and I'm sure that panelists will join in that ovation. But last but not the least, Dr. Gold, how important is the youth leadership? How do we encourage young leaders to come forth and bring that momentum, taking the leadership and learning that leadership from people like Dr. Cantor, Dr. Golden, Dr. Verma, who is really, this panel will not exist if we don't have people like Dr. Cantor. He came to Sydney, and 2 years later we have this panel. So how do we build that engagement with youth and promote young leaders to come forth and take that momentum?
I think we have to make academic medicine a place that people want to stay. A lot of the people that I look up to that are even in my kind of contemporary, like in my peer group that I know would have changed medicine, have already left medicine. There are people of color who would have done amazing things to change the system and couldn't handle being in the system. So we have to change it before they leave. and we have to make it a place that they want to stay and want to be. So we need to do things to encourage that. We need to think about how we're mentoring them. We need to think about the spaces we're creating for them. We need to think about the safety that exists for them. We need to create spaces for young people to have leadership earlier. I think that it's really hard to be excited about things when you look at people who've been in jobs for 40 years and you have no way of moving. There's no term limits. There's no people, people just hang out in jobs forever. So you can't see where your future momentum is when you're younger. I had to create my own position. My job I made up over COVID. I was doing leadership and I said, I need a job. Like, I don't see anyone moving in education. I've been doing all of this work over COVID. I need a title. That's how I got my title. That's not normal. Like, most people don't do that, so we have to encourage people to learn how to ask for things. And like, I know how to do that because I had good mentors. And I think that that's really important, and that has to come from everybody. And I think we can do that.
Dr. Gold, on that note, I just want to summarize the session for today. I think we have heard from really esteemed panelists from across the globe, from China, from US, Canada. And I think we had some lived experiences and our anecdotes from what we can do to change in our systems. We had very engaged panel and panelists and the attendees today. So thank you everyone for joining us today. I want to really acknowledge Dr. Cantor for bringing us together on this platform, and AAHC-I entire team. There's a lot of work that goes behind, and I really want to acknowledge Katie and Christine. Thank you, everyone. And you'll notice a quick poll will pop up, and we ask that you please share your feedback with us and give us the best marks you can give. And our last session will be tomorrow. It'll start at 12 p.m. Eastern Time. AAHC-I Student Leadership Initiative, Ignite Talks, so on and so forth. So we hope everyone has enjoyed the session today, and I look forward to seeing you again very soon. And thank you so much for attending. And I wish that in your practice, you continue to drive that compassion, justice, and leadership. Thank you so much.